Hello everybody, Dr. Patel here, and today we're going to be talking about when is it actually a good idea to get a knee replacement. So we're continuing on our series of knee-related talks this month. If you missed any of our previous discussions, then please feel free to reach back out to us via DM. You can email us, or you could check out previous videos on our website or on our Facebook page. So you can reach us at fxregencenter.com. If you like this video, or if you like other things, if you want to spread the knowledge, then please share this video, like, subscribe, all that kind of fun stuff. And if you have things that you want me to discuss or talk about, then please feel free to reach out. Again, you can comment, DM, or email us at info@fxregencenter.com. So thanks so much for joining us. I think we have some international folks joining us as well. Hi, Zaid. Hope you all are doing well. And today I think is a really important topic to kind of cap off our knee discussion for the month is when is knee replacement actually necessary? Because if you've heard me talk before, obviously I'm not a surgeon, and most people come to me trying to avoid knee replacement surgery or avoid surgery in general. But if you've heard me talk before, you've heard me say that sometimes surgery is absolutely necessary. There are certain things that we can't treat in a non-surgical fashion, and doing something or sending a patient to a surgeon may be the optimal choice, even though there are technically risks that are associated with it. So, if you have severe knee osteoarthritis and if you were told you were bone on bone, a knee replacement surgery may be something that was suggested to you. And maybe you're thinking like, all right, do I need to, actually, bite the bullet and go down the surgical route, or are there options to consider outside of surgery? And I'm going to go through kind of all of that today. Okay, so to kind of recap, the most common indication that somebody may be recommended to have knee replacement surgery is osteoarthritis, right? So osteoarthritis, or wear and tear of the joint, is something that is actually a very common thing. It's actually the most common thing, probably more common than any other medical condition, is when we have degeneration or wear and tear occur to a joint. Knee osteoarthritis is one of the most common things that occurs and does not necessarily equal pain, right? Just because we have arthritis does not equal pain. But if we have arthritis, then we are predisposed to getting that joint aggravated if we're not moving correctly, if we have poor nutrition, if there's various other components that can play into a knee becoming painful. But just because we have knee arthritis by itself is not a reason to get a knee replacement, because the term arthritis refers to wear and tear, but ultimately is a spectrum, right? We start with some abnormal motion in the joint, some looseness of things like the ligaments. You slowly have some wearing of the shock absorbers. You have some slow deterioration of the cartilage, which is the smooth surface of the joint. And then over time, we have some changes that occur to the bone. The bone starts to get rougher. Eventually, the bone starts to get bruised, and eventually the bone starts to break down. Now, a lot of people are told that they have bone-on-bone osteoarthritis, and what does that exactly mean, right? So when we look at this picture here of this knee, this is a knee, an example of a knee X-ray that shows the thigh bone over here, the lower leg bone over here, and you can see the space between the bones. And you can see that on this side here, there's not really any space, right? So this is what somebody would call bone-on-bone. But the term bone-on-bone is not a medical term, even though it sounds very technical. The term bone-on-bone is not a medical term, and I've seen patients that were told they had bone-on-bone knee arthritis, where in fact there was actually plenty of space between the bones. And depending on where you go to get your x-rays, unfortunately, there are some unscrupulous players out there that will do an x-ray from a different angle to make things look like they're more or less bone on bone. So just because you've been told that you have bone on bone knee arthritis really doesn't mean anything quite yet. Even if you have bone on bone arthritis, I've had patients come to me, and again, you've seen me or heard me say this before, "Doc, my right knee's killing me," and they look at them and their left knee is more bone on bone than their right? But so it's just the presence of this advanced osteoarthritis or bone on bone arthritis is not necessarily a reason to get a knee replacement surgery. Certainly, that in combination with certain other things can lean us towards a knee replacement surgery, but that in itself is not really enough. Now, when I see patients, I have kind of 3 criteria loosely that I say for if I would recommend a knee replacement surgery or not. Number 1 is not if the knee has bone on bone appearance, but if there is significant deformity that is occurring. So when we have that knee that's putting pressure more on one side than the other, and there's more bone on one side versus the other, and if that knee is gradually bowing outwards or getting more knock-kneed, if it's early deformity that is occurring, then that might be something that we can slow down the progress of and improve the symptoms associated with. But if there's significant deformity, then that's something that we can't necessarily treat with just conservative treatment with things like physical therapy and injections. So that first criteria that I have is how much actual deformity are we dealing with as far as the knee arthritis is concerned. The second criteria that I have is, have we tried other conservative treatments, right? Again, even if we have a little bit of deformity, if we haven't tried the appropriate physical therapy to strengthen the muscles around the knee, if we haven't used bracing to kind of keep the knee into a better position, if we haven't tried injection treatments to help the biology of the joint, using regenerative medicine treatments and things along those lines, then have we exhausted all the possible treatment choices? And then the third criteria that I have is really what is the level of pain that we're dealing with. I do a lot of second opinions and things for patients from across the country, and a lot of times, I'll be honest, I have a patient, I'm scheduled for a knee replacement in 2 weeks. The pain's been going on for 3-4 months. I've not had any physical therapy. I don't have any deformity. We had a cortisone injection that lasted for a few weeks, but then now I have pain again, and my pain is like a level of 3 out of 10 and on average. Well, criteria 1 and 2 right off the bat have not been met, but criteria 3, that the pain is about a 3 out of 10 on average, that's a scenario where I kind of want to pump the brakes a little bit. Now, when I say 3 out of 10, what do I mean? On a scale of 0 to 10, 0 being no pain, 10 being you need to be rushed to the hospital, right? The absolute worst thing in the world. Now, you're not 10 out of 10 if you're walking on your knee, right? You're not 10 out of 10 if you're able to hold a conversation. 10 out of 10 is so extreme that things are horrible, right? So on that spectrum, if your pain is not more than a 5 out of 10, on average, I would say let's pump the brakes a little bit. 5 out of 10 more often than not. So if you're saying that you wake up and you're a 5 out of 10, as you start moving, you're getting to a 6, 7, 8, 9 out of 10. And you're that way for all day, every day. That's a different conversation, especially if we've tried other things, and especially if there's deformity that is occurring. Well, that's a scenario that a knee replacement makes a lot of sense. But if you're sitting at 3 out of 10, yeah, it's annoying. The pain's not allowing you to do the things that you want to do, but the level of pain is really only a 3 out of 10. Then I say let's pump the brakes and just analyze it just for a minute. And the reason is this. There is some research that shows that up to 40% of patients after knee replacement still have some kind of pain. And that number may or may not be different. Each surgeon individually has their own data and their subset. So there's certainly some surgeons that have a track record of only 10 or 20% of patients still continue to have pain. But there's some research that shows that up to 40% of patients after knee replacement surgery still continue to have some level of pain. And for those that have pain, the average pain is about a 4 out of 10. That's an important statement. So 4 out of 10 patients, up to 4 out of 10 patients continue to have pain that averages a 4 out of 10. Then we gotta recognize that if you're sitting at less than a 4 or 5 out of 10 on a regular basis, right, then we may want to reassess and see what other things can we try before going down the route of an irreversible surgery. But if your pain is regularly sitting at 6, 7, 8 out of 10 on the pain scale, if we've tried physical therapy, if we tried injection treatments, and we've tried, everything under the sun, weight loss, nutrition, bracing, etc., and you're starting to develop deformity of the knee, well, that's definitely something a scenario that we need to say, all right, maybe a knee replacement is the right thing for you. Now, if you don't meet those criteria, well, there are things that can be considered, and we've discussed this already in previous episodes. Things like physical therapy, exercise, nutrition, and injection treatments. For mild, moderate conditions, things like even a cortisone injection is not the end of the world. Certainly, we don't want to repeat cortisone injections, but the gel injections or hyaluronic acid injections could be a very reasonable option. With PRP or platelet-rich plasma, at this point, there's going to be close to 40 randomized controlled trials comparing PRP to cortisone and gel injections and placebo, by and large showing that PRP could be beneficial for knee osteoarthritis, particularly for those mild to moderate cases. But what about those more severe cases, right? So what if you hit one of those 3 criteria? Let's say your pain is averaging more than a 5 out of 10, but you don't have deformity and you haven't tried other conservative things, then what options are there available for you? Well, there's some really interesting stuff in terms of research. The PRP being an option, but as we get more severe in arthritis, cell therapy treatments could be something to consider. So there are a few studies now at this point that show that bone marrow cell concentrate or even adipose tissue can potentially provide benefit to knee osteoarthritis. This is actually a study that compared bone marrow to adipose tissue, fat tissue for knee osteoarthritis, and this was a retrospective review of registry data showing that by and large injecting into the knee joint with bone marrow had benefit, and so did the fat, and similar benefit at that. So that's options to consider is using a liposuction, mini liposuction to get some adipose fat graft, or using a bone marrow aspirate concentrate inside the knee. Now, as things get a little bit more severe, though, we need to kind of think a little bit more comprehensively. And this was some really interesting research that was published a couple years ago out of France with one of the forefathers of regenerative medicine, Dr. Philippe Hernegue, published 15 years of research in which patients that had both knees with osteoarthritis, one knee got a knee replacement, the other knee had bone marrow cell concentrated cells, bone marrow aspirate concentrated cells directly injected into the bone of the knee. And this was really, really compelling data because nearly 80% of patients were able to avoid knee replacement with the bone marrow knee. And by and large, they preferred the bone marrow knee over the knee replacement knee. So if we don't meet those criteria for getting a knee replacement, there are a lot of options that we can consider at this point. So definitely something important for us to recognize. Why is it that we try to avoid knee replacement at all, right? It sounds simple enough. Let's just take our knee out and put a new knee in, right? It's not quite that simple. It is a large surgery. There are risks that are associated with it. There is a recovery period, and there are folks that end up with decreased function or decreased range of motion or things along those lines. In rare, extremely rare circumstances, but it does occur, there are things like, infections, and even worse, there have been reported cases of the knees having to be like freaking amputated and things. Now that's extraordinarily rare, so I'm not fear mongering here. Like I said, if you meet those criteria of deformity, of trying other things, and of pain that is at a higher level on a regular basis, it might be very reasonable to get a knee replacement. But it's not a simple thing that we should just do because we're in pain. So I'll show you quickly what does a knee replacement actually look like. This is an interesting video I just found on YouTube. You can look up knee replacement on YouTube and see everything. This is I don't even know who this is. The Professor Bellman's did this YouTube video, and I'm just going to kind of show briefly what a knee replacement looks like. This is obviously sped up a little bit, but basically this is a patient that's already anesthetized. By the way, graphic. I should probably have said this warning already, but super graphic, so watch at your own discretion. But this is what kind of a knee replacement actually looks like. So I think it's important to view this, right? To recognize this, and see that it's not a small thing, right? So that's the end of the femur that they're drilling into to remove some of that bone before putting that prosthesis in. I'm looking at my comments over here. Dr. Maddie. This is an orthopedic surgeon, by the way. Just wanted to blow up your spot. But thank you so much for commenting. He mentioned that only 70% of people are happy with knee replacements. That's a pretty profound statement, right? That means if 70% are happy, that means 30% of people are not happy with their knee replacement in one way, shape, or form. Now, that doesn't necessarily mean that they still have continued pain. So I've had some patients after knee replacement have no pain associated with it, but they actually have decreased range of motion. They have decreased function, and they still have asymmetries in terms of the way they walk or the way they move, and that's really important, right? Because even if we replace the joint that has arthritis, right, get rid of the things that are causing pain, so to speak, there's the risk that there's still going to be symptoms. So why do symptoms still exist after knee replacement surgery? So I just mentioned that there could be decreased range of motion, scar tissue, things along those lines. But what causes pain in that up to 40% of patients? Number one, if there's a problem with the prosthesis itself, the problem with the hardware that's implanted, sometimes that hardware can get loose. Or if there was, God forbid, inappropriate hardware that was placed, something along those lines. Infection, things along those lines can cause issues. But let's say the knee replacement went perfectly. You've healed successfully from it. Shoot, you have great range of motion. Everything is going well as far as that knee replacement is concerned. Even in those situations, we could still continue to have some level of pain. Why? Because sometimes it's not the knee joint itself that was causing the pain in the first place. We have ligaments, tendons, muscles that surround the knee joint that could be the things that were contributing to pain. So, if those were the things that were the issue in the first place, and the knee arthritis was, just knee arthritis and a normal part of living and aging, then we could have done the surgery with neglecting the fact that there was other pieces of the picture, right? What else can cause pain that continues in the knee? Well, what if the pain wasn't coming from the knee at all in the first place? Patients with hip arthritis or other, tendon or labral issues in the hip joint can actually have pain referring down to the knee. And even things like pinched nerves in the low back, right? You've heard me say this before. A nerve irritation of the low back can actually refer pain to the knee as well. So God forbid we haven't taken a step back and looked at the whole picture and looked at the joint above and below. We haven't looked at the back. We haven't looked at the soft tissue that surrounds the knee, but we just put up an x-ray and see some arthritis that's bone on bone and say, all right, let's do a knee replacement. Well, we might be missing a piece of the pie, right? completely missing the thing that's causing the issue in the first place, which is why we need to really be comprehensive, and why that criteria that I mentioned really is important. And for those of you that are just joining me, the criteria that I have for someone to go through what we're seeing right now, which is what a knee replacement is if the knee has significant deformity, right? If you're very, very knock-kneed or very, very bow-legged. Number two, if you have tried a lot of conservative things already, right? Physical therapy, exercise, nutrition, injection treatments, bracing, all of those things, and yet you still have symptoms. And number three, if your pain is more often than not sitting at higher than a 4 or 5 out of 10. And if we have those criteria, we've tried things, we've looked at the whole picture, and we're still pointing to that knee, then a knee replacement makes a lot of sense. This crazy surgery that we're looking at right now actually makes a lot of sense for specific situations. And sometimes surgery is absolutely necessary. Sometimes it is necessary for us to do something like a knee replacement. But if you're watching this right now, you better believe you're going to want to do this only if it's necessary. So I'm going to skip ahead here so we could see what the final product here, because this, by the way, this isn't, this is sped up, so you can imagine that this takes some time. It's not a small surgery, but overall, it can do, pretty well overall. People do recover well from knee replacement surgery. As Dr. Maddie stated, only 70% of patients are happy with patients, but that means 70% of patients are happy with their knee replacement surgery, right? So sometimes knee replacement is necessary. I hope you all got the hint, got the message. I hope that all made sense to you. If you have questions about your knee arthritis, you can feel free to comment, DM. You can email us at info@fxregencenter.com. Or if you have any other questions about anything else, or if there's something specific that you want me to talk about in the future, then please reach out. Now that we're in July, shoot, time is flying. Now that we're in July, we're going to be shifting gears off of the knee, and I believe we're going to be shifting onto low back conditions. So please stay tuned. At one point or another, we're also going to throw in some spattering of knee again. We're going to have Lexi, our patient care coordinator, who's also a personal trainer, coming in and giving some exercises for the knee, exercises for the low back. So please stay tuned. Again, if you like this, please like, share, subscribe, all that fun stuff. Hope you guys have a great 4th of July weekend. Happy Independence Day. Wishing you all the best, and I will see you next time.